1, 2,
And
Patients here.
send me an email.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's Carper.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
You know, if you are working on a standard medical surgical floor, your job has a very specific geometry to it.
Well, right. It's very physical.
Exactly. Like a patient fractures a femur, the x-ray shows you this jagged white line, and you stabilize it. The parameter is just physical. But the moment you step onto a psychiatric unit, that physical map vanishes completely. I mean, the x-ray machine is entirely useless.
Yeah, the IV pumps, the vital sign monitors, they aren't your primary tools anymore.
Because the tool is you.
Yes. In psychiatric care, the therapeutic relationship itself is the primary clinical intervention. Like, if you administer the exact right dosage of an antipsychotic, but you get the interpersonal relationship wrong, the treatment fundamentally fails.
Wow.
And for anyone listening who is preparing for clinical rotations or, staring down the barrel of a nursing board exam like the NCLEX, this is where the terrain gets incredibly complex. You cannot just memorize lab values here. You have to master the mechanics of human connection.
Right, which is why we're taking a strict 80-20 approach to this massive textbook excerpt on the foundations of the therapeutic nurse-client relationship.
The high-yield stuff.
Exactly. Our mission today is to cut through the heavy theoretical fluff and extract the highest yield 20% of the content that gives you 80% of the understanding. We're looking for the priority assessments, the safety red flags, and the clinical judgments you actually need to keep patients safe.
Because the stakes on a psych unit are life and death. Setting boundaries, managing confidentiality limits, mitigating your own internal biases.
Those aren't just customer service training, right?
No, absolutely not. They are the absolute core parameters of psychiatric safety.
Okay, let's unpack this. Let's start right at the baseline of how trust is actually constructed. Because outside of a hospital, everyone thinks they know how to build trust. You smile, you make eye contact, you say polite things.
Right, standard social rules.
But for a psychiatric patient, especially one experiencing acute paranoia or severe anxiety, artificial politeness is practically perceived as a threat.
It is. You have to consider the pathophysiology of anxiety and trauma here. A client in a state of acute distress has an amygdala that is just firing on all cylinders.
We're on a high alert.
Exactly. They are neurobiologically scanning the environment for danger. And that is where the concept of congruence becomes your first major clinical requirement.
Congruence.
Right. Congruence means your internal state, your verbal communication, and your nonverbal body language must perfectly align.
Which, sounds easy until you're actually in the room. Imagine a scenario where an escalating, angry patient is yelling at you.
Terrifying for a new nurse.
Yeah. And your clinical training tells you to recite the script like, I'm here to help, you are safe, but your autonomic nervous system is screaming that you are in danger, making you physically step back and dart your eyes toward the exit.
And the patient is going to read your physiological reaction, not your clinical script.
Precisely. And if they detect that disconnect?
The therapeutic alliance is dead on arrival. Psychiatric clients are so hypervigilant. If your voice contradicts your posture, the client will inherently trust the posture. Every time.
So maintaining congruence requires an intense level of emotional self-regulation. You have to actually manage your own fear before you can manage their crisis.
You really do.
And that emotional self-regulation gets severely tested when we hit the divide between empathy and sympathy. This is a massive trap, isn't it?
Oh, huge. It's probably one of the most common concepts students confuse on exams.
Because we use the words interchangeably in everyday life. But clinically, the distinction is the difference between empowering a patient and actively harming them.
I love the analogy you use for this.
Right, the quicksand one. Think about it like this. Sympathy is jumping into a pit of quicksand with a patient and crying about how terrifying the mud is.
Right.
Empathy is standing firmly on solid ground, acknowledging how terrifying the quicksand must be for them and throwing them a rope.
What's fascinating here is that visual perfectly illustrates why sympathy is considered a clinical hazard. Sympathy shifts the emotional center of gravity in the room.
How so?
Let's look at a classic exam scenario. A client is deeply distraught because their adult child refused to visit them. A sympathetic nurse might respond by saying, "Oh, I know exactly how you feel. My son has been ignoring my calls lately too, and it just breaks my heart."
Oof. The nurse thinks they're building rapport, but they just projected their own unresolved family dynamics onto the patient.
Exactly. The patient's grief has been entirely hijacked.
Wow. So suddenly the patient stops processing their own emotions because they're trapped in the nurse's emotional reaction. The therapeutic space has been contaminated by the nurse's ego.
Yes, sympathy creates enmeshment and dependency. It blurs those professional lines because the focus is now shared or entirely shifted to the clinician.
So what's the empathetic, high-yield therapeutic response?
It relies on techniques like reflection and clarification. The empathetic nurse says, "You seem very upset that your family didn't arrive today."
So it holds space for the distress without making it about the clinician. It says, I see your pain, and I am strong enough to hold it without falling apart myself.
Exactly. But keeping your ego and your personal history out of the room is incredibly difficult. You cannot be a clear mirror for a patient if your own mirror is covered in blind spots.
Right, and the source material uses the Johari Window to map this out, which is a really fascinating framework for clinical self-awareness.
It is. The Johari Window maps personality into 4 distinct quadrants. Quadrant 1 is the open self, what you know about yourself and what others clearly see.
Okay.
Quadrant 2 is the blind spot. These are behaviors everyone else sees in you, but you are completely unaware of. Quadrant 3 is the hidden self, the private traumas you consciously conceal. And Quadrant 4 is the unknown, latent traits no one has discovered yet.
And the danger zone for a clinician is that blind spot. Picture a nurse who views themselves as highly structured and deeply caring, but the rest of the unit, and crucially the patients, reads their tone as rigid, punitive, and dismissive.
Oh, we see this all the time.
If you do not actively work to shrink that blind spot by seeking honest, sometimes painful feedback from your peers, your unrecognized behaviors are going to unconsciously trigger your patients on a daily basis.
Shrinking that blind spot is how you elevate your clinical practice, which ties directly into Carper's 4 patterns of knowing.
Right.
In nursing school, we focus heavily on empirical knowing, the objective science. Knowing that severe alcohol withdrawal causes tremors and spikes a pulse rate.
The measurable stuff.
Exactly. Then there is personal knowing, which is the intuition derived from your own life experiences. Next is ethical knowing, which drives your moral compass, like advocating for a patient's rights, even when it's administratively difficult.
But the pinnacle of psychiatric care is aesthetic knowing.
The art of the practice.
Yeah, aesthetic knowing is the ability to sense a shift in the clinical environment before anything objective happens. It's walking into a day room and noticing that a patient's pacing cadence has changed slightly.
Or their breathing is just a bit shallower.
Exactly, telling you they're about to escalate to violence well before they ever raise their voice. It's synthesizing all the other types of knowing into pure clinical intuition.
Which is why the addition of a 5th pattern by theorist Munhall is so provocative.
Oh, the unknowing.
Yes! After years of training to gather knowledge, Munhall insists on the vital necessity of unknowing.
I have to admit, the concept of unknowing feels entirely counterintuitive. Wait, as a highly trained professional, aren't you supposed to know everything? Why is unknowing a vital skill?
Because in psychiatry, knowledge can very quickly harden into prejudice. If you are assigned to assess a patient with borderline personality disorder and you walk into that room knowing the clinical stereotype that they will be manipulative, attention-seeking, and combative, you've predetermined the outcome of the interaction before you even speak.
You're treating a textbook diagnosis, not the human being in front of you.
Exactly. The text highlights a brilliant case study illustrating exactly that danger. A Hispanic male client refuses to be treated by a male nurse because the client holds a culturally ingrained idea that nursing is exclusively women's work.
Okay.
Meanwhile, the male nurse is secretly relieved to be taken off the case because he holds a racist preconception that Hispanic men are inherently violent and difficult to manage.
Wow. So both the patient and the nurse walk away feeling completely validated in their knowledge. And as a result, absolutely zero therapeutic work takes place.
None.
So unknowing is the disciplined practice of recognizing your own assumptions, setting them aside, and approaching the patient with a completely open mind. It's admitting that despite your degrees, you have no idea what it is like to live inside this specific patient's reality.
Beautifully said. And that active, vulnerable curiosity is the engine that drives Hildegard Peplaw's phases of the therapeutic relationship.
Right. Peplaw gives us the chronological roadmap: orientation, working, and termination. And right at the beginning, in the orientation phase, where you are building the contract and setting ground rules, we encounter perhaps the most testable, highest liability concept in psychiatric nursing.
This raises an important question regarding secrecy. What happens when a patient asks you to keep a secret about harming themselves?
The absolute limits of confidentiality.
Yes. We constantly tell patients that the therapeutic relationship is a safe space. But the 1976 legal case of Tarasoff versus Regents of the University of California fundamentally redefined what safe means.
This is huge for the NCLEX.
Massive. The Tarasoff case established the legal and ethical duty to warn. This is a massive safety red flag. If a client makes a specific homicidal threat against an identifiable person, your obligation to patient confidentiality is completely overridden by public safety.
You have to act.
You are legally mandated to notify the attending physician, the police, and the intended victim.
You cannot promise to keep a secret, period. If a patient says, "I'll tell you something important, but you have to promise not to document it," your immediate response has to be establishing that boundary. I cannot make that promise. If it involves your safety or the safety of others, I have to report it.
Which changes the dynamic of the working phase, where you are actively exploring the root causes of a patient's trauma.
Here's where it gets really interesting. The working phase is where we see two psychological phenomena just explode to the surface: transference and countertransference.
These mechanisms are critical to understand because they feel so deeply personal when they happen. Transference occurs when the client unconsciously displaces the emotional charge of a past relationship onto the clinician.
Give me an example.
Well, a client might suddenly become incredibly hostile and resistant to your care, not because of any error you made, but because your tone of voice subconsciously reminds them of a deeply abusive parent.
So the patient is essentially hallucinating an emotional dynamic. They're overlaying the ghost of their abuser onto you. And the real danger here is if the nurse lacks the self-awareness we talked about earlier and takes that hostility personally.
Yes. If the nurse gets defensive and argues back, they spark countertransference.
Countertransference is when the clinician reacts to the patient based on their own unresolved childhood wounds, right?
Exactly.
Let's say a nurse grew up as the youngest child whose opinions were constantly dismissed. If a patient experiencing transference tells that nurse, "You don't know what you're talking about, I'm not listening to you," the nurse's own psychological baggage gets triggered. They might react with intense, disproportionate anger.
Suddenly, you are no longer doing therapy. You just have two traumatized people arguing in a clinical setting, reenacting their respective family dysfunctions.
It's a mess. And navigating those invisible emotional landmines is what makes the final phase, termination, so incredibly delicate. When the clinical goals are met and it's time for discharge, you're effectively ending a profoundly intimate relationship. And the textbook notes a fascinating behavioral shift here. Patients often regress right at the end. Their original symptoms might mysteriously return, or they become inexplicably angry. Structurally, why does brain do that?
It is an unconscious defense mechanism against the pain of abandonment. Many psychiatric clients have profound trauma surrounding loss. A healthy, structured termination of a relationship is something they may have never experienced in their entire lives.
That makes so much sense.
By regressing or claiming the medication stopped working, their brain is attempting to prove they still need clinical care. It's a stalling maneuver to prevent the loss of the nurse's support.
Knowing that the patient is acting out purely from a place of grief, the temptation for a clinician to blur the boundaries must be overwhelming. You see a patient hurting because they're losing you. Isn't it a bit cool to just cut them off if they still need you? Why can't the nurse agree to meet them for coffee after discharge?
I get asked this constantly by students. On the surface, it sounds compassionate, but it's actually a massive clinical violation because it completely alters the power dynamic and the fundamental purpose of the connection.
How so?
A therapeutic relationship is asymmetrical by design. It exists entirely to serve the patient's healing, bounded by time and clinical goals. A social relationship, like a friendship, is a two-way street based on reciprocal emotional needs.
I see.
If you transition a patient into a friend, you strip away the protective boundaries that allowed them to be vulnerable in the first place.
You're no longer a safe, objective clinical harbor. You're now a very powerful individual in their personal life who happens to carry all of their darkest psychological secrets. It traps the patient. And this brings up the specific roles a nurse occupies. You are an educator, a caregiver, an advocate. But the source material places a massive warning sign over the parent surrogate role.
Slipping into the parent surrogate role is remarkably easy. When a client exhibits childlike behavior or if they require highly intimate personal care, the nurse might unconsciously adopt an authoritative maternal or paternal tone. I know what is best for you, just do what I say.
It feels efficient in the moment to just parent them into compliance, but structurally, it destroys the adult-to-adult autonomy necessary for healing. You aren't equipping them with coping skills, you are just reenacting a toxic parent-child dynamic. The client will either rebel against the control or become completely submissive and dependent, both of which entirely halt therapeutic progress.
The boundary red flags are everywhere once you know what to look for. Keeping secrets for a patient, sudden increases in phone calls outside of clinical hours, giving out your personal address, or accepting significant gifts.
What about self-disclosure?
That's the warning that often surprises novice clinicians.
I think a lot of people operate under the assumption that sharing a mutual struggle is the best way to build rapport. Like, if a patient is devastated about a divorce, saying, "Oh, I went through a brutal divorce last year too, I know how dark it gets," feels like profound empathy.
It is a massive trap. Selective self-disclosure is a razor-sharp clinical tool. Used briefly and purposefully by an expert, it can normalize a patient's experience. But the absolute golden rule is this: never, under any circumstances, disclose a current unresolved problem or a recent deeply painful trauma to a patient.
Because doing so shifts the spotlight back to you. The moment you share your unresolved trauma, the patient inherently feels the need to carry the emotional weight of your story. They might even try to comfort you. The therapeutic space is no longer theirs. It has been co-opted by your need for validation.
And maintaining this level of intense emotional discipline, constantly monitoring your physical congruence, fighting off the urge to be sympathetic, recognizing countertransference, and holding firm boundaries against a patient practically begging for a friendship.
It's exhausting.
It requires a monumental expenditure of cognitive energy.
So what does this all mean? It leads directly to the mechanical breakdown of the clinician. Compassion fatigue. You can't be a lifeguard if you're actively drowning. We're not just talking about needing a weekend off. This is a physiological and psychological depletion of the nervous system.
It is essentially amygdala burnout. When you spend 12 hours a day absorbing severe trauma, managing psychiatric crises, and hyper-regulating your own emotional responses, your psychological reserves simply run dry.
Yeah.
You lose the capacity for that aesthetic knowing we discussed. You literally can no longer perceive the subtle behavioral cues of a patient escalating because your own brain is locked in survival mode.
And when a clinician's empathy reserves are depleted, critical safety errors happen. The boundaries we just outlined begin to slip. A burned-out nurse might become rigidly cynical and ignore a patient's suicidal ideation. Or conversely, because their personal life is exhausted, they might start seeking emotional validation from the patients.
It's so dangerous.
Professional self-care is not a wellness luxury. It is a mandatory clinical safety parameter. A burned-out clinician cannot accurately assess homicide risk, cannot practice unknowing, and cannot safely navigate a patient through an emotional crisis.
Exactly. If you cannot regulate your own nervous system, you cannot co-regulate a patient's.
So bringing this all back to our 80-20 mission for this deep dive. If you are walking onto a psychiatric unit tomorrow or sitting down to take your boards, here is the high-yield summary of how human connection operates as a clinical tool. First, trust requires absolute congruence. Your body language must match your verbal reassurances. Second, empathy empowers the patient by holding space for their pain, while sympathy actively harms them by projecting your own emotional baggage.
Third, the Tarasov exception establishes the duty to warn. Homicidal or suicidal threats legally override any promise of confidentiality. Fourth, you have to navigate Papla's phases while constantly monitoring yourself for countertransference. And finally, you must aggressively protect the professional boundary. No social enmeshment, no parent surrogate lecturing, and strict limits on self-disclosure.
The relationship itself is the treatment. You are the instrument of healing. It requires immense skill to operate that instrument cleanly.
But I want to leave you with a final thought to mull over that extends beyond the clinical floor. While this text is strictly about psychiatric nursing, think about your own everyday interactions. When a friend calls you in crisis, are you genuinely holding space for them, or are you offering sympathy that is really just an excuse to hijack the conversation and share your own story?
Wow. Are you rushing in to fix their problems like a parent surrogate, rather than empowering them to find their own solutions?
What would happen if, just for today, you practiced unknowing with the people closest to you? If you stripped away all the assumptions and historical baggage you've built up about them over the years and genuinely met them exactly where they are right now?
That completely reframed what it means to actually listen to someone. Thank you for joining us on this deep dive. Take these frameworks, protect your boundaries, and we'll catch you on the next one.